everyone. Thanks for having me, and I'm really excited to give everyone just a little bit of an update on PSC research, what's happening here in Australia, and what's been going on internationally as well. So it might seem like an uphill battle. We don't really have therapeutics for PSC yet, and sometimes it may feel like this, that pharmaceutical companies are more interested in other diseases rather than PSC. But actually behind the scenes, there's a lot going on, and I just wanted to give everyone a bit of an update. And lots of things going on. Nothing official yet, but there's a lot more understanding and investigation going on into the background of the disease and therapeutics. So what's happening in Australia? So couple of things. So I'm sure some of you may be involved in a study held by a client, which was looking to investigate oral antifibrotic agent called PLN 74809, so bexotegrast. So this is an oral antifibrotic agent which has also been developed for idiopathic pulmonary fibrosis, where there's actually scar tissue in the lung. And obviously the company's hope is to look at that, see if it reduces the amount of scar tissue in the liver. That's been investigated in smaller healthy cohorts, and it's found to be safe. And I'll just elaborate more on the phase 2 study in the next slide. So that's one of the studies that has been ongoing. It probably close to closure, but it's sort of multi-center and international as well, so quite a big cohort. Secondly, looking at targeting the gut microbiome as a treatment for PSC. So this is a study held in Queensland, so a randomized placebo-controlled trial. So what that means, basically looking at therapy versus a placebo, and looking at the effect in both groups to see if the drug that we're interested in is having a therapeutic effect. So they're looking at patients with PSC plus or minus inflammatory bowel disease, which as you would know is very common, and the effects of the antibiotic vancomycin on these outcomes. So those are the sort of two sort of bigger pharmaceutical trials going on at the moment. And then some of the observational trials that are going in Australia. So ProPromise is one that is run by us in Victoria, multi-center. Hopefully will continue to grow in the next couple of years. So we're just collecting all patients with PSC and collecting clinical data. And there's optional sample collection as well for blood storage, so we can analyze things over time, and also looking at liver stiffness changes, MRI changes over time. And what we're doing is pairing with another big Australian IBD microbiome study called the AIM study. And with that study, it's a shorter 2-year study, but 3-monthly blood and stool and saliva swab samples. And we're actually looking at microbiome changes over time, and it'll be very interesting to see as we collect data on diet, IBD, sort of disease parameters as well, and look at how all that correlates. And it might help us sort of look at disease targets in the future. So very exciting stuff going on. So as mentioned before, this is the INTEGRIS PSC clinical study looking at the investigation of PLN 74809, so looking at sort of adult patients with large duct PSC. And so what it targets is really transcellular membrane receptors, and they actually help to activate a certain molecule, TGF-beta, which is increased in fibrotic tissues. And this has been found in sort of liver tissue that they've removed from PSC patients undergoing transplant, and they found that there's elevated numbers of these molecules. So there's been quite promising results from sort of early mouse models and safety results from phase 1 trials. So we look forward to see some of the results, that preliminary results that will be published later this year. And as mentioned before, manipulation of microbiome. This is more used in the pediatric space, and I'm sure some of you may have experience with this. Vancomycin is a very minimally absorbed antibiotic, and there has been quite a few studies, more so in the pediatric cohort than adults, but small case series demonstrating that the antibiotic itself increases sort of regulatory T cell cytokines. And what that means, the immune system is always in balance, and it sort of increases some of the better molecules. And also comparing vancomycin with other antibiotics such as metronidazole, tetracycline, azithromycin. It's actually one of the better ones that improves your blood test compared to these. Other smaller pilot studies and case reports, we do see it used sometimes post liver transplant to prevent recurrence of disease, or in patients who do have recurrence to reduce progression of disease. And there's one very small pilot study, 12 weeks, looking at efficacy of fecal transplant to sort of change the microbiome in a better way. And this has shown reduction in ALP, which is a marker of liver injury. So all very small case studies, nothing really to sort of quantify us to use it regularly. But there's a lot of work study going on, so very interesting. And this is the AIM study that I spoke about before. So there's a QR code on the top left. So feel free to scan it if you're interested. It doesn't matter where you are in Australia, anywhere you can participate. So once you scan in, you'll just need to input some details, and then you'll get a couple of emails, questionnaires. Stool sample packs will be sent out to you. And you can do everything at home, put it back in a prepaid envelope, send it back. So really encourage everyone to participate. You don't have to have IBD. You can have IBD itself, PSC, with or without IBD, and you can even get your healthy relatives to participate. So, as many people as you can, try to get them involved. So, great. Let me, all right. So clinical trials overseas. So there's a lot more trials going on in sort of UK area, and the PSC support website, which is down the bottom left, that's a great resource. Obviously, many of you will be based in Australia, I presume, but just example of what's going on overseas. I've only picked the trials that are still recruiting. There are quite a few that are closed or not recruiting, not ready for recruitment just yet. So there's a couple of observational trials, like the first one, similar to the AIM study that we're doing, collecting blood and stool samples. There's evaluating itching in PSC. A couple of interesting ones. So Pacific study, which is evaluating EP547. So that's actually a receptor on the neuron, so the nerve endings. So they've got little receptors, and they get activated by elevated bilirubin, bile acids, things that sort of activate the neuron and cause that itching sensation, which is obviously the most frustrating symptom and very difficult to treat. So looking at targeting that neuron receptor and seeing that can modulate itch in PSC. Polarized, looking at stromal cell therapy, which is actually through an IV drip, that's been looked at in sort of mouse models and shown to be efficacious, but in PSC, there's still ongoing studies. Spring study is pretty exciting. So we're looking at targeting an inflammatory and fibrotic molecule called CCL24. And this has been found to be upregulated in liver tissue and serum in patients with PSC as well. So by using an antibody to target that and reduce that, we may be able to demonstrate improvements or reduce disease progression. I'm sure those of you with inflammatory bowel disease will be familiar with antibodies and how they target inflammatory molecules in our body, like infliximab, for example. So none of the ones we use for IBD has been shown to be efficacious for PSC as yet, but hopefully, there's some other new ones that are in the works. And vistas, so looking at volixibat in patients with cholestatic itch. So volixibat is a apical sodium bile transporter, which is found in the terminal ileum. So that's where the end of the ileum and the start of the colon, so where they join. And that's typically where bile salts get reabsorbed from the colon back into the liver. So by reducing some of that reabsorption, we reduce the overall bile acid burden in the body. So that's been used for sort of pediatrics where they have genetic disorders that result in intrahepatic cholestasis and buildup of these bile acids, but hopefully we can use this to translate to our adult PSC population. So a lot of research going on in that area. obviously there are challenges, and which is why we probably haven't sought out therapy yet. Funding's always an issue for orphan diseases, as we call it, and I don't really like the term because I don't see it as an orphan disease, but it is a rare condition. So it's harder to find participants, and it's such a heterogeneous disease. So some of you may not have changes on MRI, some of you might have changes on MRI, some may have normal liver function, some may not. So it's within this small cohort, within itself, there's a lot of differences, which makes it more challenging to see changes in clinical trials. Obviously, clinician knowledge is a big one as well, because unless you're a specialist hepatologist, you may not have the sort of expertise. And also, how do we measure efficacy of drugs in PSC? Other than the fact that within the cohort there's so many different patient characteristics, what we use to measure efficacy is also challenging because we don't really have a very good gold standard. So we use serum biomarkers like the ALP or alkaline phosphatase. As I mentioned, we can use imaging, and use liver biopsy. Patient-reported outcomes I feel is very important as well. What can we do to improve care of patients with PSC? Refer for clinical trials, and if you're a patient, ask your doctor if there are any clinical trials that you can participate in. I think the jury on ursodeoxycholic acid's still out, but recent guidelines have suggested trialing if there is abnormal liver function tests, and it does seem to improve that. So that might be worth trying. And what's the evidence behind regular imaging? I guess we'll go through that in a bit. So I just wanted to talk about surveillance in PSC. The recent guidelines from Europe and America have suggested regular imaging with MRI, with or without serum CA19-9, which is a cancer marker. You can see there's a bit of discrepancy between European and American guidelines. And in the old British UK guidelines, they only recommend an ultrasound for gallbladder surveillance. So the literature is not very strong, and we're unclear about a lot of the recommendations. However, there has been a couple of studies, including our own. So just want to highlight, there's been an international multi-center study that's shown that regular imaging has shown improved survival. However, a prospective study looking at patients over 5 years who have annual MRIs and annual CA19-9 have actually shown that there's been no improvement in cancer-related survival. So, we're still unclear what the true benefit is. So we decided to look into our Australian data. And this was a retrospective cohort study we published last year. Looking at the patients who were in the study, we wanted to evaluate the impact of regular MRI, which I'm sure a lot of you are getting, looking at the impact of overall survival, transplant-free survival, and cancer-related survival. So you can just see the squiggly lines just represent that the two patient cohorts were quite different. So if you look at red, the differences go all the way to the right, which is a difference of mean difference of over 0.4. But you can see that we adjusted that. So the two groups were very similar, the green squiggly line on the left. So we wanted to make it a little bit like a trial. However, it's obviously very difficult to do. So we use this sort of statistical methods to weight the cohorts. And you can see on this curve, the blue in patients who get regular MRIs, that they actually, less of them died over the follow-up period compared to the red, where patients were not having regular MRIs. And looking at cancer outcomes, you can see, similar to the other study, that actually the lines are pretty similar. There's no difference between survival post-cancer diagnosis. And this is because we're still not picking up cancers early enough. So only 2 patients were asymptomatic at diagnosis, and most patients had later stage cancers. And whether or not imaging it annually or 2-yearly, 3-yearly made a difference, we found that there was no difference with more frequent imaging, although the numbers were smaller in these cohorts. So it's got to take this information with a grain of salt. So we did find that regular MRI imaging was associated with improved overall survival. So it may not really be for cancer surveillance per se, but rather it'll be useful for disease progression and may just indicate sort of more healthcare involvement, which allows us to focus on other things. So we do need to look forward into this, but I think the more information we get, the better. And I think regular imaging with your clinicians is very important. And the ProPromise study, as I mentioned before, the observational one that we're running, we actually get additional MRI features to help with prognostication, looking at fibrosis of the liver. We correlate patient-reported outcomes with disease severity, look at microbiome analysis in the future in corroboration with the AIM study. So watch this space. Okay, so halfway into the talk, I just wanted to give a few updates from the European Liver Congress earlier this year in Vienna. A lot of interest in PSC, a lot of good posters and talks. So I just wanted to share a couple of interesting posters. So I've sort of divided them. So first one, diagnosis and screening. So these posters are very busy, but I just wanted to sort of summarize. I'll just summarize them for you. So this poster was looking at sort of the role of blood tests, liver function tests, histology, and imaging in diagnosing PSC. I'm sure some of you or you know other patients who would have had abnormal liver function tests for a long time, and only the diagnosis of PSC comes to light if there's complications or they see another doctor and they've sort of got the clinical suspicion for it. So they actually took a cohort of patients from Helsinki University Hospital, so a large cohort, 395 patients, and looked at what are the parameters that actually give us the highest yield to diagnose PSC properly. And they found that having IBD, having a high ALP, and having a positive P anchor test, if you had all three together, the probability of a true PSC diagnosis was over 90%. And they've developed they've called it the HELP screen score. So there might be scores in the future that might be useful for screening relatives, other patients. So this will help with making it ease of diagnosis. So we're moving away from liver biopsy. We still need MRI to confirm diagnosis, but at least by using these markers, we be able to better triage patients who need an MRI. Looking at the diet and microbiome, so obviously we don't really have any diet recommendations for patients at the moment, but I just wanted to bring up this interesting paper that's been published recently. So this was a prospective study of a gluten-free diet for patients with PSC and inflammatory bowel disease. So there's been some sort of preclinical or at least pre-human studies in mice models that show that a gluten-free diet has shown to have anti-inflammatory effects, especially on the bowel. And it's not just the gluten, but it's also a component called ATI, amylase trypsin inhibitor. And by reducing this reducing this in your diet, it actually translates to anti-inflammatory effects. So they administered an 8-week diet to patients with PSC IBD, and they wanted to see if this improved inflammation on colon biopsies and also liver stiffness based on FibroScan. So I'll just go to the next slide because it's a bit bigger. So this was published this year. So if you look at the bottom right, actually you can see that so the top left histological scores and top right FibroScan. So there's actually no significant difference between changes. And the bottom fecal calprotectin, we looks at inflammation in the stool and also ALP in the blood. So even though there was no significant difference between both groups, what they did show was there was reduction in pro-inflammatory cytokines and pro-fibrotic cytokines in the blood. And actually intestinal barrier function was improved in the gluten-free cohort. So even though they didn't meet their primary outcomes, there's actually some positive markers. So I think this warrants a sort of longer trial, and because 8 weeks is fairly short, and I'm sure a lot of patients has concomitant celiac disease as well. So it would be of interest to sort of study the differences in between. And how does diet sort of relate to PSC and IBD, other than, other than that? So sometimes there's the gut microbiome is responsible for metabolizing primary bile acids, making them less toxic in the colon, and subsequently, hopefully, less toxic for the liver as well, due to the gut-liver axis. So very busy slide, but I'll just summarize that they looked at changes in the microbiome and how it interacts with bile acids in the stool. And they found that in patients with PSC, they had decreased amounts of a certain fecal bile acid, and this was correlated with changes in the microbiome as well. And they found that this correlated with disease markers, so increased bilirubin and increased inflammatory markers. And they also found, interestingly, that alcohol increased one of these bile acids. So I don't think we have enough to say whether you should, whether alcohol is beneficial for PSC, but definitely if you have advanced liver disease, alcohol should be avoided. So I just wanted to put this slide to show that the microbiome does interact with bile acids, and this sort of correlates with sort of the complex pathophysiology of PSC. So hopefully we can learn how to manipulate this in the future. And another way that microbiome interacts is responsible for metabolizing and producing certain vitamins and things as well. So we found that vitamin B6 in this poster. So they looked at patients from Norway and characterized the number of patients with vitamin B6 deficiency, and they sort of validated this in a German and Swedish group. And they found that patients who had lower B6 actually did not do as well in patients who had sort of normal B6 levels. And this has been found in other studies that it's related to sort of low microbiome gene count and altered bacterial composition. I wouldn't say that this means that replacing vitamin B6, might change things. I think it's just more a reflection of what's happening in the microbiome and in the gut. But however, this would be something reasonable to check and replace. Like I said, we don't have enough data to use it as a therapeutic at this stage, but vitamins are, very safe, can be replaced very easily. An important thing at this stage, with the amount of evidence with our diet, just eat a healthy diet, making sure you're having enough nutrition. There's all these studies going on, but not enough to sort of, say what kind of diet we should be eating at the moment. So monitoring, like I said before, regular imaging is important, and there has been found that MRIs can, by assessing the degree of bile duct stricturing, it does allow us to sort of predict outcomes and plan for management. So this is a new score called the district score, where they look at changes of bile ducts in the liver and also outside the liver. And depending on the degree of stricturing and the amount of dilatation, which happens if the stricture is very narrow, they can sort of use that to determine outcomes and predict disease progression. So this is something that we can apply very easily. It's a very good inter-reader observation between radiologists, and this will help us in sort of looking at patients and planning what to do. So which leads me on to the next slide, where if we do find a very significant stricture, some of you may have had what we call a ERCP, which is an endoscopic retrograde cholangiopancreatography, where we actually put the camera down while patients are asleep, go through the small bowel into the bile ducts, and we can use balloons or stents to open up the bile ducts and relieve congestion or stricturing of the bile ducts. So this group actually found that patients who had regular scheduled ERCP rather than on-demand ERCP, which just means that if patients get symptoms, then you do the ERCP. They found that there was improved outcomes, essentially. And in patients who didn't respond between the first and second ERCP, they didn't do as well. So this, so the conclusion from these two posters is, one, if we're doing regular imaging, we're finding strictures that are pretty significant, then probably we should be considering scheduled ERCP or semi-regular ERCPs rather than waiting for patients to develop significant complications. So, we don't have a lot of good data. This is mostly retrospective, and there has been previous studies on looking at patients with dominant strictures or high-grade strictures, as we call it as well. I think there's more and more data coming through that perhaps semi-regular opening of the bile ducts may help preserve liver tissue and improve outcomes. But yeah, still more studies need to be done. And I think it does vary from center to center, and some centers might have more experience with dilating or intervening with these strictures and some may not. So it just depends where you're being managed. But yeah, definitely worth a discussion with your clinicians when they're looking at the MRI. Ask them, what kind of strictures do I have? Do they need therapy, etc. All right. And looking at other sort of monitoring, recent EASL guidelines or European guidelines have also suggested yearly to second yearly FibroScan, so looking at liver stiffness. And also there's a new serum enhanced liver fibrosis test, which is just a blood test, which allows us to sort of look at the amount of scarring in the liver. So this poster actually found that the ELF test and liver stiffness as measured by FibroScan, it does gradually increase over 5-year follow-up. And it is the ELF score is more strongly associated with outcomes compared to the ALP, which we classically use in clinical studies, and also FibroScan. So what this suggests that the ELF score might be a more robust predictor in PSC compared to FibroScan or ALP, and might be a sort of better, closer gold standard that we can use to look at clinical study outcomes. So what it is, as I mentioned, it's a non-invasive blood test that actually assesses 3 components of liver fibrosis in the blood. And you can see on the panel down the bottom, patients with a score of above 9.8, that's the more advanced stage, and patients less than 9.8, that's the sort of milder stage. This is currently only commercially available in Australia for over $200. But if you go through the ProPromise study, we are collecting serum for it to be processed for ELF score as well. And you don't get the results immediately because we do them in bulk and we're aiming to analyze them down the track, but that will be something that we can use for future. Okay. So just in the last couple of minutes looking at treatment, I sort of spoke about therapeutic trials previously, so I don't want to labor on too much, but just an interesting poster looking at oral vancomycin. What this study showed that oral vancomycin actually led to a reduction in an enzyme called bile salt hydrolase, which is an enzyme that's produced by some of the bacteria in the gut. And it actually changes bile acids from a more sort of less toxic form to a more toxic form. So what oral vancomycin does, it reduces that. So technically you can think that it reduces the amount of toxic bile acids in the gut due to its effect on the microbiome. However, something to note was that it was found that there was increased emergence of vancomycin-resistant antibacteria in the bowel as early as 1 week into treatment. So even though vancomycin does seem like a promising treatment, there does seem to be sort of increase in gene expression for resistant microbiome. So I think this needs further careful evaluation rather than just prescribing antibiotics per se. Obviously, there are other sort of proper indications for vancomycin use, such as Clostridioides difficile, or if you have pouchitis, you might be having vancomycin therapy more often. But whether it's used for regular use in PSC, I think still needs to be further investigated. So closing remarks. Sorry, there's a lot of scientific stuff, clinical stuff, but I just wanted to say that there's a lot of interest in PSC, and we are very, as clinician scientists, or pure scientists, there's a lot of interest and clinical trials, mouse model trials ongoing. As you can see, because you're always interested to know what can we eat, what can I do to help the disease. There's a lot more research going to understanding the diet and how our microbiome interacts with our diet and how it interacts with disease. So we don't know yet, essentially, even though I've showed you a lot of information. But in the future, we probably will be more informed on how to manage and monitor and guide you. And I just reiterate again that any research you participate in will benefit future generations, possibly yourself in the future. So if you can, please participate in any clinical research. Thank you for having me. And if there's any questions, I'll be there at the Q&A to answer them. Thank you.